All right, let's dive in. Today we're tackling something that might sound a little intimidating at first. Secondary hemostasis disorders.
Yeah, it does have that ring to it, doesn't it? But honestly, this stuff is super interesting once you get into it.
It really is. I mean, we're talking about the system that literally keeps us from bleeding out.
Exactly. Like every time you get a cut, this system is what makes sure it actually stops bleeding.
And to get a handle on all of this, we've got a whole pile of research articles and studies here.
Yeah, we've got the latest on everything from how these disorders actually show up, the symptoms, to the lab tests that help figure out what's going on.
Like a medical detective story, right?
Totally. We start with the patient's story, how they're actually presenting, what they're experiencing. That's our first clue.
So it's more than just seeing blood, right? There are different ways these bleeding disorders can show up.
Absolutely. One way is what we call spontaneous bleeding, and that can be pretty alarming. You wake up with bruises all over, or you get a nosebleed that just won't stop.
Okay, yeah, that's definitely a red flag. What about something less dramatic? Like, what if you just bruise really easily?
Right, that could be what we call superficial bleeding. It's more on the surface, think those easy bruises, frequent nosebleeds, that kind of thing. It might not seem as serious as spontaneous bleeding, but it's still a clue that something might be off with how your blood is clotting.
Okay, so we've got bleeding you can see, but what about bleeding you can't see, like internal bleeding?
Right, that's deep bleeding, and it can be a real problem. We're talking about bleeding into the joints. It's called hemarthrosis, super painful, or even bleeding inside the muscles. It can really impact your movement and just your quality of life.
Ouch, yeah, that doesn't sound good at all.
Yeah.
Anything else to watch out for?
Well, there's this tricky one called delayed bleeding. So everything seems normal at first, but then hours, sometimes even days later, the bleeding gets excessive.
Oh, wow, so it's like a delayed reaction almost.
Exactly. And it can be really sneaky. Like I remember reading about this case. A baby had delayed bleeding after a circumcision. Turned out to be this rare factor 13th deficiency.
Oh, wow. So the timing of when the bleeding happens is really important, especially with babies.
Absolutely. It can be a huge clue. Like, delayed bleeding in a newborn might mean a rare factor deficiency, but if an adult suddenly starts having spontaneous bleeding, that could be pointing to something completely different.
So it's all about putting the pieces together, right? Like a puzzle.
Yeah.
But the patient's story, that's just one piece.
Yeah.
We need to head to the lab to get the whole picture.
Absolutely. Lab tests are essential. They help us confirm what we suspect and really understand what's going on with the clotting system. And there are a few key tests that we use pretty much every time.
Okay, so let's put on our lab coats and dive into those tests. Where do we start?
Well, one of the most common is the APT, the activated partial thromboplastin time. Think of it like a stopwatch, timing how long it takes your blood to clot. If it takes longer than usual, something might be up.
Okay, so a prolonged APTT, that's like a red flag that the clotting process isn't running smoothly.
Exactly. It means something's not quite right with the clotting cascade, that series of steps that lead to a clot. Now, another key test, another timer, if you will, is the PT, or prothrombin time. Often you'll see it reported as INR.
And I remember reading that while the APTT is affected by certain factors like factor VIII and IX, which are linked to hemophilia, the PT can actually reveal things like liver problems or even a vitamin K deficiency.
Exactly. Each test gives us different information. And here's where things get even more interesting. You see, bleeding disorders aren't always something you're born with. Sometimes they develop later in life because of other health conditions.
Wait, really? So you could have a perfectly functioning clotting system, and then something happens that throws it all out of whack.
Yeah, exactly. A really dramatic example is something called DIC, disseminated intravascular coagulation. It's like the clotting system goes haywire, clots start forming all over the body. It's like a runaway train. And it can be triggered by serious infections, trauma, even cancer.
Whoa, DIC sounds pretty scary. Are there other acquired disorders that can mess with a clotting system?
Oh yeah, definitely. Liver disease is a big one. Remember, the liver is like the factory that makes a lot of the clotting factors. So if the liver isn't working right, it can't produce enough, and that leads to problems.
That makes sense. So if the liver is the factory, are there conditions that affect the actual building blocks of the clot itself?
You're thinking about fibrinogen, the protein that forms that meshwork of the clot. In primary fibrinogenolysis, that fibrinogen is getting broken down way too quickly so the clot can't form properly.
Okay, so we've got DIC, where there's too much clotting, and primary fibrinogenolysis, where a key part of the clot is being destroyed too fast. How can doctors tell those apart?
That's where the D-dimer test comes in handy. It basically measures how much fibrin, that's a product of clot breakdown, is in the blood. High levels of D-dimer. That could point to DIC. But if the D-dimer is normal or even low, that could suggest primary fibrinogenesis.
So the D-dimer helps differentiate between those two very different scenarios. This is all starting to make sense. But we've been talking a lot about acquired disorders. What about the ones that are inherited, passed down through families?
Right, those are important too. In fact, the most common bleeding disorders are actually inherited. And they often come down to a deficiency in certain clotting factors. And those deficiencies, they're there from birth.
Like hemophilia.
Right, exactly. Hemophilia A and hemophilia B, they're both caused by a deficiency in a specific clotting factor. And because these deficiencies are genetic, they can cause bleeding problems from a very young age.
I bet there are specific lab tests for those too, right? To diagnose these inherited conditions.
You bet. Besides the APT, PT, and fibrinogen we already talked about, there's something called a mixing study. It's really clever, actually.
A mixing study, what's that?
So basically, we mix the patient's plasma, that's the part of the blood without the cells, with some normal plasma that we know has all the clotting factors, and then we see what happens.
No,
If the clotting time goes back to normal, it suggests that the patient was just missing a certain clotting factor, like their body wasn't producing enough of it. But if the clotting time is still prolonged, well, that could mean there's something called an inhibitor present.
An inhibitor, what's that?
It's basically an antibody, but instead of attacking germs, it attacks a specific clotting factor, preventing it from doing its job. It's like a little saboteur messing up the whole clotting process.
Oh, wow. So it's like adding the right ingredient, but something's blocking it from working properly.
A perfect analogy. Now, here's the thing about inhibitors. They're actually most often seen in people with severe hemophilia who receive factor replacement therapy.
So their body is actually attacking the treatment that's supposed to help them.
It's kind of wild, right? Their immune system sees the replacement factor as something foreign and tries to fight it off.
Wow, that's crazy. It seems like there's always something new to discover with these bleeding disorders.
It's true, and there's a lot more to talk about. We'll dive deeper into these inhibitors and explore those specific factor assays and specialized tests next time.
Welcome back. So we ended last time talking about the mixing study and how it can help us figure out if the problem is a missing clotting factor or one of those sneaky inhibitors.
Right, it's a key piece of the puzzle.
So let's say the mixing study points to a missing factor. How do we actually figure out which one it is?
Well, that's where factor-specific assays come in. They're designed to measure the activity levels of individual clotting factors, like factor 8, 9X, you name it.
Oh, I see. So it's like checking each worker on the construction crew to see who's missing.
Exactly. And some deficiencies are more common than others. Like if someone has a prolonged APTT and the mixing study corrects, the first thing we usually check is factor 8.
Because hemophilia A is the most common, right?
Exactly. It's a factor 8 deficiency. Makes sense to start with the most likely culprit.
Totally. But you mentioned that some factor deficiencies can be acquired too, right? So can these factor assays give us clues about other health problems?
Absolutely. For example, they can tell us a lot about how well the liver is functioning. Remember, the liver is responsible for making a lot of those clotting factors.
Right, so if multiple factors are low, it could be a sign the liver is struggling.
Exactly. These assays are pretty versatile. They give us insight into more than just the clotting system.
Speaking of specific factors, remember that case we talked about earlier, the baby with the delayed bleeding after the cut?
You mean the one with factor 13th deficiency? Yeah, that one's interesting.
So how do you diagnose that one?
Well, for factor 13, there's a special test called the 5-molar urea test.
5-molar urea. Okay, that sounds intense. How does that work?
So factor 13th is a bit different. It's not directly involved in making that initial clot. It's more like a sealant. It strengthens the clot after it's already formed.
So it's like the glue that makes sure everything stays together.
Exactly. Now, clots formed without factor 13 are much more fragile, and the 5-molar urea test uses this to its advantage.
Oh, I see. So it tests how well the clot holds up.
Right. If the clot dissolves quickly in the urea solution, that points to a factor 30 deficiency.
Interesting. Okay, so we've got these tests for specific factor deficiencies, but what about those disorders that affect both primary and secondary hemostasis, like von Willebrand
Oh,
disease.
yes. For von Willebrand disease, we use the von Willebrand factor assay. It measures both the amount and how well the von Willebrand factor is actually working.
It's like a double agent, right? Helping platelets stick together and protecting factor VIII.
Exactly. But there are actually different types of von Willebrand disease, each with its own quirks when it comes to how much or how well the von Willebrand factor is working.
So diagnosing von Willebrand disease isn't just a one-and-done kind of thing.
Nope. Some folks have mild forms, just minor bleeding issues, while others have more severe forms that can look a lot like hemophilia A. The assay helps us figure out which type it is and make the right treatment decisions.
This is so complex. It's amazing how much goes into diagnosing these bleeding disorders.
It really is a detective process, bringing together the patient's story, the physical exam, and all these lab tests. But even with all these tools, the most important thing is understanding how these disorders impact people's lives.
You're right, we can't lose sight of the human side of things.
Exactly. And that's what we'll be talking about in the next part, the challenges and the triumphs of living with bleeding disorders.
And we're back. It's been a wild ride through the world of secondary hemostasis disorders.
It has, but we've spent a lot of time talking about the science, the lab tests, all those details.
Right, but now it's time to talk about the people, the ones actually living with these conditions every single day.
Absolutely, because behind every diagnosis, there's a whole story.
So what's it actually like? Living with a bleeding disorder, I mean. What are some of the biggest challenges?
Well, for a lot of people, it's this constant balancing act. Having to be careful, thinking about activities, always being aware of potential injuries.
And knowing what to do if a bleed does happen.
Exactly. It's like always having to be a few steps ahead. And for some people, especially those with more severe forms, there's a big emotional burden too.
Yeah, I can imagine. The fear of a spontaneous bleed, the uncertainty.
Exactly. Not knowing how your body's going to react, how it might impact your life, it can be a lot to carry.
So it could be physically and emotionally draining.
Yeah.
But what about treatment? Is there anything that can help people manage these conditions, live a more normal life?
Oh, absolutely. There have been some amazing advancements, especially for those hereditary factor deficiencies like hemophilia A and B. Replacement therapy is really the cornerstone of treatment.
Replacement therapy.
Yeah, so basically, you give the person regular infusions of the clotting factor they're missing. It's like giving their body the exact tool it needs to build that stable clot.
I see. So it's like supplementing what their body isn't making enough of.
Exactly. And the goal is to prevent bleeds from happening in the first place. That's called prophylaxis. And, for a lot of people with severe hemophilia, this has been huge. It lets them do things they never could before.
Wow, that's incredible. So fewer infusions, more freedom. It really makes a difference. But are there any downsides to these replacement therapies?
Well, like we talked about earlier, one potential issue is those inhibitors, the antibodies that can develop and attack the clotting factor.
Right, the saboteur.
Exactly. And that can make treatment a lot trickier.
But there are ways to manage them, right? Like those higher doses or the immune tolerance therapy.
Right. That immune tolerance therapy is pretty cool. It's basically like retraining the immune system, teaching it to accept the replacement factor.
Wow, it's amazing what science can do. Any other big breakthroughs on the horizon?
Oh, yeah, definitely. Gene therapy is a really exciting area. The idea is to actually insert a healthy copy of that missing gene into the person's cells.
Gene therapy. That sounds like science fiction.
I know, right? It's still early days, but it has the potential to be a long-term solution, maybe even a cure for some of these disorders.
That's incredible. So beyond the medical treatments, are there other resources for people with bleeding disorders?
Definitely. There are some great support organizations out there. The National Hemophilia Foundation, the World Federation of Hemophilia, they do amazing work.
What kind of things do they do?
Oh, all kinds of things. They connect people with information, resources. They even have support groups, advocacy programs, even financial assistance.
So it's not just about the medical side, it's about building a community, right?
Yeah.
Helping people realize they're not alone.
Exactly. Living with a bleeding disorder can feel very isolating. These organizations help people navigate all of that, the challenges and live a full life.
Well, this has been an incredible deep dive.
Yeah.
I'm just amazed by how complex the clotting system is.
Me too. But what's really inspiring? It's seeing how resilient people are. Even with these challenges, people are still thriving, living their lives to the fullest.
It's really a testament to the human spirit and to the power of science, to make a real difference. Thanks so much for joining us and sharing your expertise.
It's been my pleasure.